Hello, future nurses. As promised, though it's a little late, a review of the content in Unit 3. If I can get my screen to flip sides. Okay, learning objectives, right? So Unit 3 covers Chapter 18, Anxiety. I apologize first for my kids in the background. So anxiety, everyone knows it, right? It's that feeling of uneasiness, uncertainty, helplessness, right? It's normal. Everyone has anxiety. Just like everything else in psychiatry, it's on that scale. You are eustress, good stress, or distress, bad stress. And anywhere along it, that's where they need to be, right? So mild anxiety, I need to be focused, right? I don't need to worry about this. I need to be able to do this, right? So test anxiety. Some students have mild test anxiety. It increases learning and it enhances your concentration. However, if you have extreme test anxiety, that's ineffective and maladaptive. You just struggle on the test. Anxiety warns about danger, and it's a normal part of survival and growth. That uncontrolled anxiety and those ineffective or maladaptive coping skills, that's what leads individuals to go see their healthcare providers, right? So as we said last slide, it's on a continuum. Positive focused anxiety, we learn and grow. Maladaptive, right? Responses from anxiety on the levels when we get to panic, that is where the struggle is. So this is essentially table 18.1 in the book. Anxiety occurs as a result of a threat to oneself. So signal anxiety, right? That's mostly behavioral. Learned response to an anticipated event. I know I have a test tomorrow, so I am going to be anxious because tests equal anxiety. Anxiety state. Individuals' coping abilities become overwhelmed, right? This is crisis. You have coping skills and your coping skills work up until a point, and now all of a sudden your coping skill stops working. And you just don't know what to do. An anxiety trait, this is learned component, right? You have a parent who's anxious, and as such, you are now anxious. This is Freud, right? Personality is developed by the age of 5. So you learn from those around you. And if you learn to be anxious, you will be anxious. Physical symptoms of anxiety, right? Muscle tension, fidgeting, headache, sleep problems, fight or flight. Are you going to run away or are you going to start fighting? Coping mechanisms. Anything you do to decrease the effect of that anxiety, decrease the effect of that stress, right? So a maladaptive coping skill, doing drugs, right? Excessively drinking alcohol, shopping, eating ice cream. Positive coping skills, deep breathing, meditation, relaxation, progressive muscle relaxation. Mild, moderate, and severe, and panic, right? 4 levels of anxiety. Mild is just kind of maybe us on a day-to-day basis, right? You're relatively comfortable. You feel safe, calm. Moderate, vital signs are still normal. There may be some tension. You're a little bit more alert, a little bit more attentive. Severe, where we start seeing that fight or flight, that autonomic nervous system, right? So we're seeing vital sign changes, muscles rigid, senses are affected. Perceptual field is narrowed. You can only see what is right in front of you. You can't focus on anything else. You have problems problem solving, right? An overload. Panic, flat panic attack, right? Honestly, you think someone having a heart attack. It's going to escalate. They're pale, blood pressure decreases, hypotension, pain and hearing sensations are minimal. They just can't focus on anything. They're unable to take any stimuli. There is no probable problem solving or logical thinking. Disassociation may occur. Disassociation is honestly, it's the flight. They separate from reality, right? Disassociation is when you're driving in your car and all of a sudden you're home and you don't know how you got home, being removed from the body, maybe angry, maybe terrified, completely disorganized behavior. So that continuum, defense mechanisms. Defense mechanisms are Freud, right? They're unconscious. We don't choose why or when we use defense mechanisms. right? So defense mechanisms. These are Freud, right? These are unconscious. This is something where you don't know you're using them, but your unconscious uses them to make you comfortable, to lessen the negative feelings, right? Because crisis, your ability to cope with anxiety is overwhelmed, and new coping behaviors must be developed to successfully resolve the source problem. If you don't have the coping skills, we use defense mechanisms. Table 18.2 is something good to check out. Okay. Table 5.1 and 18.2, right? Defense mechanisms. We watched this video in class. I'm not going to play it now, right? Some of the defense mechanisms. Projection, right? Your husband's cheating on you. Wait, you're cheating on your husband, but you accuse your husband of cheating on you. So you're the one doing it, but you're blaming someone else for it. Is projection. Rationalizing, right? I'm going to go steal from the Target dollar spot because it's only $1 and Target makes so much money. I've spent millions at Target, y'all. I can steal from the Target dollar spot. Rationalization. Reaction formation. Behaving in a way opposite to what you feel, right? So remember in first grade, you had crush on little Chris, but whenever you saw Chris, you would push him down on the playground. You're pushing him down on the playground to say, I don't like you, but in reality, you do like him. Regression, right? Reverting to a childlike behavior. This is a lot in pediatric patients. Though the kid is fully potty trained, something traumatic happens. The parents get divorced. They move, and they start having accidents again. Y'all, denial. I can't even go into denial, right? Y'all just know what denial is. Repression, stuffing their experience so down that you forget about it, right? You put it down into your unconscious and you just pretend it didn't happen. Sublimation. I want to punch everyone. I'm so angry. So instead, I'm going to go become a WWE wrestler. We're taking a negative impulse and turning it into something positive. Disassociation, detachment from reality, right? We daydream. We go into our own fantasy land. Compensation. If you can't draw, but you're really good at dancing, you throw all of your energy into dancing, right? Someone's really short, so they can't play basketball, but they're going to go become the best track star ever. So that continuum, again, right? Self-awareness and anxiety. It's contagious. It's important for us as caregivers to recognize our own coping and anxiety. How do we cope? How do we manage, right? We can't freak out on a patient. Theories related to anxiety, right? Y'all do a quick review of this. Biologic, that's internal, that's hormones, that's our genetics. Psychodynamic is Freud. That's that inherited personality trait and defense mechanisms. Everything that we have up until here, we learned from our mother. Freud loves the mother. We were super anxious because our mother was super anxious. Behavioral models. This is Pavlov and his dogs, right? So remember Pavlov and his dogs. You ring a bell and give the dogs food. You ring the bell and give the dogs food. You ring the bell and give the dogs food. So now when you just ring the bell, the dogs expect food. So behavior model. We learned from things that have happened. You know, every day if your dad comes home and has a beer, he's going to be very angry and start yelling and screaming at you. When dad comes home, as soon as he touches that beer, he doesn't have to yell at you. You just become angry. Behavioral. Anxiety is normal in children, right? It's related to their developmental level. You see phobias. You see separation anxiety, right? Separation anxiety is normal to a point. You see over-anxious and avoidant behaviors happen, right? So in children, they stop eating, you have sleeping issues, isolation, nail biting, right? They're not responsive maybe to what's going on around them. And a big one is acting out on behavioral issues. They're going to go to school and they're going to act all crazy and they're going to get in trouble. Adolescents have horrible anxiety, right? Adolescence is a tough time. And when you throw in ineffective coping and you throw in anxiety, they're going to express themselves inappropriately. Cutting, sexually acting out, right? Eating disorders, many initial symptoms of schizophrenia begin in adolescence. A lot of the social withdrawal. Not necessarily is schizophrenia, but sometimes you can see it. Providers, we have to look at it. We have to assess pediatric patients and adolescents. Adulthood, similar to young adults, right? We hopefully are going to have earlier established coping mechanisms. Developmental tasks are going to provide stressors. How do I buy a house in this housing market? How am I supposed to have kids when everything's so expensive and you can't even buy formula anymore, right? So as an adult, the successful or not successful managing is going to result in more mental health issues. Elderly adults, they just don't talk about it. They're going to deny anxiety. Socially, right, they don't talk about it, right? This is that white men over 65 are more likely to kill themselves because they don't talk about their feelings. One of the best things we can do is just sit with these clients. Hey, how are you doing? My name's Julie. What can I do for you today? Just have a conversation. There's a lot of life changes at this age. You have someone who's always been independent and now they can't drive. They can't go to work anymore. They're, now on dialysis and stuck sitting in a chair. They go to a nursing home, right? They go from completely independent to dependent, and that leads to some of these anxiety disorders. Okay, so what's an anxiety disorder? Anxiety disorders is when the anxiety gets so bad, it affects your life. This is that DSM-5 doctor level book. You have to meet the criteria and it has to affect your life in some way. Separation anxiety. Separation anxiety can be normal. That first day you drop your kid off at preschool and they're like, "What? Where are you going?" That's normal separation anxiety, right? Kids, when they learn object permanence and all of a sudden you leave the room at, 8, 9, 10 months old and they get upset when you leave the room, that is normal. What is not normal is someone who's, 13, 22. And usually if separation anxiety continues at that point, it's related to maybe that's something that happened, right? Dad went out to go get milk and he never came home again. So now I'm terrified mom is going to leave me. Or, when so-and-so left me, then I was in a car accident and I almost died and, now I can't leave their side. Therapy. Therapy is needed for that. Generalized anxiety. These are people who fret or worry about numerous things. Everything makes them worried. It's broad. It's long-lasting. It's excessive. They're going to be up all night thinking about completely irrational things. It's that snowballing. What would I do if my parents died? How would I take care of my siblings? I work at Target. I only make $8 an hour. How can I live on that? And there's no indication that your parents are going to die. They're nice, young, and healthy. But you're sitting up at night just thinking about it. Panic disorders, more common than thought. This is your arachnophobia, your claustrophobia. These are all of your phobias. Associated with agoraphobia or not associated with agoraphobia. Agoraphobia is kind of like that fear of open spaces, right? So someone with agoraphobia, they might just stay in their house all day. They might not be able to leave their house. So phobic disorders. Phobias, internal fear or reaction. These are obsessive in nature, right? So while generalized anxiety, they're anxious about everything. Individuals with phobia are going to obsess about that one thing, right? If you have arachnophobia, you're going to obsess. That shadow is a spider. What is this? It's a piece of fuzz on the floor. And all of a sudden they're panicking that it's, a spider. Everyone's going to handle it differently. It's going to vary depending on culture. How do we treat phobias? Well, meds. We're going to do anti-anxiety meds. And we're going to do therapy. With anxiety, meds are not going to go alone, right? We can give someone with a fear of flying Klonopin when they get on the plane, but they can't be dependent upon Klonopin. So what we're going to do is we're going to do therapy, right? This is a desensitization, that exposure therapy. I'm going to show you a picture of a spider. Then I'm going to show you a toy spider. Then I'm going to show you cute little daddy long legs. And then we're going to get up to that big tarantula. until eventually maybe the phobia is gone. Obsessive compulsive disorder. This is OCD, not to be confused with last week when we talked about OCPD. OCD is intrusive. It is an anxiety. So they have a thought, an obsession, right? So the obsession is the thought. The compulsion is the behavior. And they have to complete the compulsion to reduce anxiety. If we stop them from completing the compulsion, their anxiety increases. So this was my favorite example of the person with the car. Obsessive thought. I'm driving down the road. I hit a bump, right? That obsessive thought. I killed someone. I just ran over a person. Compulsion. I have to pull over on the side of the road, get out of my car, and walk around the car. Right? This is the person who has to go back and triple check that they locked the door 20 times. And usually it's a set number, right? Patient who had to put something into the garbage can 7 times, and she'd throw her garbage away 7 times. Sometimes related to cleanliness, dirt and germs, a lot of hand washing. Sometimes related to aggressive and sexual functions. Health concerns, safety concerns, right? Related to order and symmetry. This is not the fact that you click your car a few extra times to make sure you can hear the beep that you lock your car door. This is more compulsion. If I don't wash my hands just this way, I have to go in a counterclockwise circle with this specific soap, and I'm going to rub my hands, 87 times counterclockwise. Meds, we might do an antidepressant. Antidepressants, remember, are shown anti-anxiety principles, right? Prozac and therapy. Lots and lots and lots of therapy. I apologize, y'all, for this dog in the background. He's killing me. So, right, obsessive compulsive disorder. Obsession is the thought. Compulsion is the action. You have a thought. We do the action, the compulsion. Goal is to get them to just decrease the amount of times they do that action. If you had to rub your hands 87 times clockwise in a circle when you wash your hands, now you're only rubbing it 15 times, right? Maybe every third bump in the road, you stop and check to see if you hit a body. But they have to do the compulsion or else it produces anxiety. Please review the difference between OCD, obsessive compulsive disorder, and OCPD, obsessive compulsive personality disorder. Okay, other anxiety disorders. Body dysmorphic disorder. They're going to perceive a flaw in their body no matter what. They're going to have extreme cosmetic surgery sometimes, right? They think their nose isn't perfect, so then they have to go get a nose surgery. What they see is different from what everyone else is seeing. Lots of interpersonal stress because the family, if this is someone addicted to plastic surgery because their body is just not perfect no matter what they do, they're not going to understand why their family's not giving them money. You can see this sometimes in anorexia and in bulimia, right? They think they're fatter than they are. They think, how they view their body is different. Hoarding disorder, persistent difficulty with throwing things away, regardless of what the value is, right? This is that show. This is Hoarders. 20,000 boxes of cereal. This is the first box of cereal my son ever ate, and I can never throw this box away, right? This is a person who keeps their kids' teeth. If you keep your kids' teeth, I apologize. I just can't. Their teeth. They're going to have these possessions that are going to interfere with their life. Bugs, trash, hoarding animals. You can't walk into a room. Floors collapsing. Stacks of piles of stuff has no value. Right? This isn't a stamp collection from the 1800s. This is just garbage that they keep. Meds, we're going to do antidepressants to help manage the emotions, and we're going to do a lot of therapy. A lot of therapy. Trichotillomania is hair pulling. Patients have anxiety, and they cope with their anxiety by pulling out their hair. Usually pull out small strands repeatedly from the same spot. So you'll see, back of the head, a big bald spot. It can get to the point where they have no hair, they have no eyebrows, they have no eyelashes because they're pulling out their eyebrows and eyelashes. Kind of like that ritualistic behavior with the OCD, they just have to do this. They have to pull out their hair. We're going to treat the anxiety usually some type of SSRI, long-term anxiety medication, not benzos, because benzos are short-term, and we're going to do therapy. Excoriation disorder is skin picking. This is more, right? We all pick the skin around our cuticles, but this is repeated over and over and over and over picking. It's not going to heal. You're going to see, right, nursing care plan, risk for infection, because they're going to keep picking, all in response to anxiety. And then behavioral addictions, right? Not just substance abuse, but it could be gambling, working, shopping. My marriage sucks. I'm so anxious, so I'm just going to go to work. And you're going to compulsively go to work. You get so anxious, but shopping makes you a little less anxious, so you shop all the time. Sexual addiction, right? Excessive way to get out your anxiety. Let me just go have sex. Having sex makes me less anxious. I'm going to go have more and more and more and more and more sex. This isn't like, I'm having sex a few times a week. This is someone who only focuses on sex. Stress and trauma disorders, traumatic stress reaction. It has traumatic stress reaction and acute stress disorder on here. They're kind of the same. Something happens, right? There is a car accident. Acute stress is usually in that first 30 days after something traumatic happens. And then, you should be nervous after a horrific car accident. And it's going to vary depending on the person, what they find traumatic. But something happens and you are extra just hyper-focused, hyper-worked up, really struggling in those first 30 days. After the first 30 days after that traumatic event, if it kind of doesn't go away, that's where you see post-traumatic stress disorder, right? Military, sexual assault accidents, reliving traumatic events, those flashbacks, right? There's normally a specific trigger. Example we talked about in class, if someone was raped and the person who raped them wore a specific cologne, when they smell that cologne, that triggers a flashback. It reminds them of it. In PTSD, you see a lot of inability to sleep, frequent nightmares, hypervigilance, always, focused, can't relax, always alert, have to be ready. Adjustment disorder is kind of normal, right? Everyone has probably dealt with adjustment disorder. I just moved, right? I went from Texas to New York. I moved from Texas to New York, and it's very different, and I don't know how to adapt to it. My parents got divorced, and it's hard to deal with it. It's usually the first 6 months or so after something normal happens, right? It's not traumatic. It's just trouble adjusting. Over time, therapy, we can do SSRIs, right? First line medication most of the time. We can do SSRIs with those to help with that difficulty adjusting. Usually, the person's going to deal, they're going to cope, and they're going to get used to it. PTSD again, right? Pathologic anxiety. Anxiety usually occurs after we witness a severe trauma that is terrifying or life-threatening to the person. Everyone's going to react differently to different stressors. From the same event, some people will have PTSD and some will not. Intense fear, horror, helplessness, emotionally numb, alert, guarded, right? Flashbacks, anxiety, depression, nightmares can kind of complicate that picture. Rape trauma syndrome. Rape trauma syndrome is essentially PTSD for individuals who have been raped. Predictable course, fear and anguish, recovery and repair, and then adaptation. First thing we want to know when we talk to a patient, right? If you're in the emergency room and you have someone come in, the first thing we're going to ask them, do you feel safe? Who can provide you emotional support? Can I call someone for you? What resources are available in the community? Prevention is the most effective way to cope. We need to learn coping skills. Therapy and meds are needed. Medication alone will not fix anything. You have to do medications and therapy. History and physical are performed. We're going to need to know what's going on. Cognitive behavioral therapy, right? we are going to help change the thoughts that change the behaviors. Systemic desensitization. Learn to cope with one anxiety-provoking stimulus at a time. If the person's afraid of a plane, we're going to watch a movie about plane. Right? And then we're going to go just sit at the airport and watch planes take off. And then we're slowly going to just sit on a plane. Meditation and therapy animals. Right? But first, assess and provide for safety. And remember, the first step in the nurse-client relationship in psychiatry is to establish trust, right? Establish that relationship. How do we treat anxiety? I'm going to do a separate video on meds for y'all, but anxiety may be treated with various medications. Benzos, short-term use of benzos, right? We give benzos 1 or 2 doses at a time. If you have someone who's afraid of, flying, we might give them a dose of benzos for the flight. Benzos work fast, but they don't work for long. They're only going to work for like 4 hours. They're very, 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 very addicting. So we do not give them out like Tic Tacs. At least we don't anymore. Antidepressants, especially your SSRIs. Well, SSRIs are that first line for pretty much anything anxiety or depression related. So, right, that's next week's lecture too. SSRIs generally are pretty safe, right? We're going to assess for suicide. It takes time to work. And we're going to watch out for anticholinergic side effects. Antihistamines. Your propranolol. Nope, sorry, antihistamines are Vistaril and Atarax. This dog is making me lose my mind, y'all. Antihistamines, Vistaril and Atarax are some of the big ones we use. Beta blockers, propranolol, especially with that agoraphobia, a lot of those social phobias, right? Each medication has possible side effects, so we want to make sure that we're limiting the medications we use, and to do that, we're going to work with therapy. Do a nursing assessment, get the information, protect the client from injury, establish a trusting relationship. That establishing a trusting relationship is the first step, right? That nurse-patient relationship. We're going to teach problem-solving techniques. We do not give advice. We do not solve the problem. We are going to teach it to the client, and we're going to teach relaxation techniques. Deep breathing, guided imagery, progressive muscle relaxation. Okay. Chapter 19 was this? Illness and hospitalization. We flew through this in class, and we're going to flow through it now. Right? Health, absence of disease. Illness is some type of imbalance, right? So in psychiatry, it might be a neurotransmitter imbalance. When we talk about depression, it's too little serotonin. When we talk about mania, it's too much. There is multiple different cultural views of anxiety or anxiety of illness, yin and yang. Stages of illness experience. Stage 1, symptoms. Yeah, start to not feel good. Right? Maybe you just have a minor sore throat, or your nose is a little congested, or you're just a little sadder than normal. Right? We are going to maybe do something on our own. We're going to self-medicate. We're going to, get my grandma's chicken noodle soup. Stage 2 is the sick roll, right? Now you're a little bit more stuffy. You have a cough. You can't breathe out of your nose. You have a low-grade fever, and everyone's like, hey, yeah, you really are sick. So you take on the sick roll. Stage 3, your throat's still sore. You can't breathe. You can't inhale. You're coughing all night long. So you go see a doctor. Hey, you know what? Whatever you had turned into pneumonia, right? The healthcare providers are going to confirm the illness and give you treatment. Dependency. You don't do anything, right? Think about when your husband, boyfriend, whoever has the man flu, right? They're going to be sitting in bed, and we're going to be waiting on them hand and foot. You can't do everything on your own because you're so sick. Recovery and rehabilitation. Give up the sick roll and you go on with your life. Illness is going to affect everyone around them, not just the family, or not just the sick person, but the family. Anxiety, anger, denial, shock, withdrawal, right? Extreme illness, more so than just a little cold, has a big impact, right? Think about a family member having a heart attack, winding up in the hospital. Denial can be useful or paralyzing, right? So remember, denial is a defense mechanism. Yeah. Right? It's Freud. It's going to hopefully reduce the uncomfortable emotions. lessen negative feelings. I'm not as sick as, the doctor said. The cancer's not that bad. Most people are going to experience illness, recover, and go on with their lives. We have to remember that whatever is going on with that illness, no matter how bad it is, it's the priority for that person experiencing it. Hospitalization is a situational crisis, right? It relates to external or environmental problems. There's two ways people get hospitalized. It's planned in advance, or it's an emergency. Something happened, you're in a massive car accident, and you have to have leg surgery, and they're doing external fixation and stuff like that, and you have to go to the hospital and stay there. The actual crisis being removed from the home environment to be cared for by strangers in an impersonal and uncomfortable setting. Hospitals are horrible. Even when you have like a kid and it's planned, right? Being in a hospital sucks. No one wants to do it. Stages of hospitalization: overwhelmed, stabilization, adaptation, right? First it sucks, you slowly start to deal with it, and then you adapt to being there. Clients respond to the stress of being hospitalized in the same way they respond to other threats. When we're talking about psych and inpatient treatment, right, it's sometimes difficult because now you have the stigma of mental illness on it. How do my neighbor gets cancer and all of a sudden there's a meal train and everyone's bringing them food and people are coming to clean their house. But you go to the hospital because you're going to kill yourself and no one talks about it. People feel awkward. How do you do support? Employers may question, can you even do your job? And it's also maybe confirmation that someone is truly crazy. Psychosocial attention is just as good as physical care, right? People need love, right? Maslow, when you get to the higher up Maslow's level, it's not just about eating and drinking. It's about how do we care for someone. So good physical care is needed. However, we also have an accepting environment, and the patient needs to share themselves and know that we're going to be there and have trust in the therapeutic relationship. We need to support significant others and caregivers. Family members are in a crisis too. Pain management is a big part, right? It's subjective. It can only be felt by those who are experiencing it. We have to discover the expectations of pain. So if a patient has abdominal surgery and they're like, oh, my pain's like a 4, I can't manage it, we kind of need to talk to them sometimes. Well, what else can we do that's maybe non-pharmacological? Because you're going to be in pain after surgery. Natural remedies, different things, extra pillow, hot pack, ice pack. Let's try those first. Discharge planning. Discharge planning begins on admission, right? What are they going to need? What's the problem going to be following hospitalization? Maybe there's new anxieties about returning home. For people who live alone, especially older adults, and especially in psychiatry, discharge planning is vital. How do you find an outpatient provider? Right? Normally you have to see a provider within 30 days for continuum of care. What are we going to do? Okay, y'all. That is unit 3, anxiety, right? We talked about defense mechanisms, lessen negative feelings developed by Freud. We talked about anxiety, generalized anxiety, right? That fretting, those panic attacks, that lightheadedness, that elephant sitting in the chest, right? Panic attacks, kind of the heart attack, trichotillomania, the hair pulling, all the phobias, SSRIs, therapy. There's a lot of information as we start getting into these disease processes. So make sure you're reviewing it and you're familiar with all of it. If you have any questions, reach out and let me know.